Good afternoon. My name is Michael Elias, and I support business development here at the Swedish Neuroscience Institute. I would like to welcome you to today's webinar, Focus Ultrasound Treatment for Essential Tremor. Thank you all for joining. We are very glad to have you with us today and hope you're looking forward to the next hour with Dr. Tony Wong. So with all that said, I'm pleased to introduce the speaker for today's webinar, Dr. Tony Wong. Dr. Wong is a neurosurgeon at Swedish Neuroscience Institute here in Seattle, Washington. He has extensive clinical experience in the use of focused ultrasound in the treatment for movement disorders. Dr. Wong completed his medical school at Wayne State University in Michigan, his residency at the University of Virginia, and his fellowship at UCLA. Dr. Wong completed his education with numerous high honors and awards. And so, Dr. Wong, just before I turn it over to you, I just wanted to talk a little bit about the poll. So just to let you know who's in the room right now, about 57% or 59% of the people in the room with us today are patients with essential tremor or Parkinson's. 25% picked other, and 12% are a family member of someone who has essential tremors or Parkinson's, and 3% are a caregiver. So I just wanted to toss it over to you. So thank you so much, Dr. Wong, for joining us today and this afternoon, and the floor is all yours.
All right. Well, thank you, Michael, for the very flattering introduction. I just want to thank you, Michael, and everyone else behind the scenes for setting this up. And thank you to everyone else on the call for taking a little time out of their Wednesday to hear about focused ultrasound. Focused ultrasound is something I've had the pleasure of being around for over a decade. It's something I believe big in, and I'm always happy to kind of spread the good word about this therapy. As Michael mentioned, I'm based here in Seattle. I see patients in our Seattle campus as well as our Edmonds campus. I'm licensed in addition to Washington, Alaska, Idaho, Montana, and California. And so if you happen to live in or physically reside in any of those states, we are able to conduct virtual telehealth consultations as well. A little bit about my background. As Michael mentioned, I did my residency at the University of Virginia, where I had the good fortune of being exposed to focused ultrasound. UVA was one of the first sites in all of the world to have focused ultrasound. And we were involved in the trials to prove its safety as well as efficacy. Here's kind of a recent breakdown of the number of cases I've done here as well as prior institutions that I've been in. So, what is essential tremor? It's a tremor disorder that goes by multiple names. It's been called familial tremor or idiopathic tremor or even benign tremor. I think the benign tremor label is a little bit of a misnomer. I think a lot of people, might have tremor and they might go to their primary care and, they might be told, oh, well, yeah, you have tremor, but it's not Parkinson's. It's just this benign tremor. And, because people are told it's benign, they might not seek treatment. I think, many people on this call might realize that there's nothing benign about not being able to say write or feed yourself or perform hygienic activities such as brush your teeth. So just because something's maybe not Parkinson's doesn't mean it doesn't have the potential to cause severe disability in life. Unfortunately, we don't know what causes this. We do, however, know that it can cluster in families. A lot of patients that we see will report, some blood relative having this. Up to 50% of patients might report something like this. We know that it affects millions of Americans, perhaps, over 10 million. And as I said before, a lot of people might have this and be debilitated. They might not seek treatment because they're told it's a benign tremor. For those who do seek treatment, we do know that, medications are, potentially helpful, but up to 50% of patients might not get good relief from medications, or the medications might cause some sort of intolerable side effect. So when we think about, what are my options for treating tremor, The first thing that we would recommend in the medical field would be a medication. So the most popular medication to trial are beta blockers. So one of the common beta blockers is called propranolol. These medications are by trade blood pressure medications. And while sometimes effective, they can cause side effects of low heart rate or low blood pressure. So people might report that they feel tired or fatigued or what have you. Another common medication to trial is a medication named primidone. This by trade is an anti-seizure medication. This too can be effective, but can also cause, side effects of sedation, sleepiness, something like that. And then there are a variety of anti-anxiety medications that we view as kind of second-line medications for tremor. There are also wearable technologies. Calitrio is a wristwatch type device that you wear that, can provide some benefit. Below, I have some surgical options listed. So when do we consider these? We consider surgical options when the medications either don't work or cause bad side effects, and patients find the tremor disabling in their day-to-day life. So they can't do what we would call activities of daily living. So these are things like, eating, feeding yourself, drinking a beverage, text messaging or whatnot. Of these surgical options, the two main options we have are deep brain stimulation and focused ultrasound. We have two kind of older and lesser used options called RF thalamotomy and gamma knife. But, before we talk more about focused ultrasound, I think it helps to step back and think about, well, how does this procedure even work? In patients with tremor, we do know that there is, in essence, a small area of the brain that has gone, shall we say, haywire. It's a little bit more active than it should be. And because of this overactivity, patients will see excessive movement in the form of tremor. And so we have two halves of your body. You have the right half of your body and the left half of your body. Each half of the body is controlled by a half of the brain. Oddly enough, the wires in the brain are crossed, so to speak. So that is to say the right side of your body is controlled by the left side of your brain. And so what these procedures aim to do is they aim to target a small area of the brain that's overactive to reduce the activity there, to therefore reduce tremor on the opposite side of your body. So again, let's say I was right-handed and I had really bad right-handed tremor, we would propose a procedure on the left side of your brain. So let's, I know we're not here to talk about deep brain stimulation, but how does this work? This procedure has been around for many decades. It entails an actual surgery where we cut the scalp open, drill a hole in the skull, we put a wire into the brain. The wire then runs underneath the skin of the scalp, neck, and is connected to a battery pack in the chest. The battery pack then sends electricity up this wire down into the brain, and the electricity comes out the tip of the wire to scramble or jam up the brain's tremor signals, thereby reducing tremor. That's a very effective therapy. In full disclosure, that's a procedure that we do here at Swedish. But, I think for a lot of patients, when you tell them, hey, we're going to cut you open, drill a hole in your head and put this wire in your brain, I think it can be a bridge too far to cross. I think it can be a daunting thing. And, frankly, a lot of patients that we see just don't want to have the therapy. And I think that's very reasonable and understandable. And that's where something like focused ultrasound can come into play. So focused ultrasound, to be clear, it targets that same overactive area of the brain. However, it treats that area through a completely different manner. So I have a little cartoon up here showing, a person with a magnifying glass focusing the rays of the sun and burning a small hole on a piece of paper. That's kind of akin to what focused ultrasound is like. So during this treatment, there's this helmet that goes around your head. The helmet has about 1,000 individual ultrasound beams, and they fire beams from all different directions and angles, but they converge on one single spot. And it's only at that spot that the temperature gets hot enough to make a small ablation or burn. And so what we can do is we can move that focus of energy to that abnormal area in the brain causing tremor. We can then make a small controlled burn about the size of a green pea using MRI guidance to reduce the abnormal activity there, to therefore reduce tremor on the opposite side of your body. And so, the big thing with this therapy is that, again, we don't have to cut you open. We don't have to drill a hole in your skull. We don't have to put a wire into your brain or a battery pack into your chest. And so on the right here, you can see an example of someone before the procedure and someone after. Full disclosure, this is not someone I treated here, but later on in this talk, we'll show you plenty of examples of people who have been treated here. So next I have a video, kind of a cartoon to kind of demonstrate what this procedure looks like.
During the treatment, you will lay down on the treatment bed inside the MRI scanner. The medical team will be in the control room, and you will be conscious and able to communicate with them. Your head will be positioned in the focused ultrasound helmet, which is filled with water, and you will have a blanket to keep you warm. You will be given a stop sonication button if for any reason you want to stop the procedure. MR images are taken to plan the treatment. Your physician will first apply light doses of ultrasound energy to identify the right spot in your brain for treatment. Then, full intensity ultrasound energy will be applied. The treatment bed will move in and out of the MRI. After each application of ultrasound energy, you will be asked to do tasks such as drawing spirals. This is so the physician can evaluate the improvement of your tremor and any potential side effects.
So this is what it actually looks like. Here's a patient that we treated a couple years ago. Here's a picture of him. His head is placed in this head frame. The patient is then put on this table. The frame is then connected to this ultrasound helmet. And the procedure is performed with the patient awake, and we use MRI imaging in real time, so we can, down to the second, monitor how big this burn we're making is, how hot the burn is. And again, because we're doing this awake, we can assess the patient in real time to make sure that the tremor is progressively getting better and better. And so what does this look like for the patient? This is a rough schematic of the procedure. It's broken down into 4 separate phases, and this takes place over the course of a couple hours. We, by convention, do these procedures here on Friday in Seattle. So stage 1 or phase 1 is the patient prep. This entails a full head shave. Oddly enough, for as high-tech as this device is, it does not work with hair, and so we have to shave the head. Once we shave the head, we put a halo head frame onto the head. It gets pinned at 4 spots. There are 2 spots above your eyebrow and 2 spots behind your ear. We'll inject some local anesthesia to make sure that your skull or your scalp is numb before we put this frame on. The frame does have a tight kind of squeezy sensation that will go away after about 5 to 10 minutes. Now, the frame serves a very important purpose. As we talked about earlier, this therapy is used to target an area of the brain the size of a pea. And because of that, we don't want your head to move even the slightest bit. So that frame is there to hold your head still. So it's ultimately there for your safety and your benefit. So once the frame is on, we move on to step 2, which is the planning portion. So we'll put you on the MRI table. We'll connect the frame to the ultrasound helmet. And then you'll go into the MRI tube for about a 15, maybe 20-minute scan. This part of the procedure is pretty boring. We don't give any sort of ultrasound treatment. We're just taking pictures. I tell the patients having this procedure, at this point is a great time to just close your eyes, take a snooze, and have a nap. After that 15 to 20-minute scan, we'll move on to phase 3 called targeting. So what we'll do here is we will give you very low doses of ultrasound energy. You might not feel anything. You'll hear the machine make this humming noise. Now, the purpose of this step is to make sure the device is accurate. And so on our computer, because we're using MRI, we can see exactly where that ultrasound beam is going. And the idea is that, before we make that burn, we want to make sure everything's lined up and accurate. So that might take 3 or 4 quick treatments over perhaps 5 minutes. And then once the accuracy is confirmed and everything's lined up, we move on to the fourth and final step of the procedure. So this is the test and treatment phase. So what we'll do here is we will start to give you more and more energy to heat up that area in the brain. As we heat up that area in the brain, we'll slide you out of the MRI tube, and then we'll test your tremor. So I frequently will hold a clipboard over your head and have you use a marker to try to draw circles and spirals. And so the idea is that as we heat things up, we should see that tremor decrease and get better and better. That confirms to us that we're in the right spot. Once we know we're in the right spot, energy goes up even further to make that burn. When we give you more energy, you might feel something like a brief, a headache, a little sense of pressure on the head, a sense of warmth. A lot of patients might also feel a brief sensation of something like levitation or floating. Those sensations are pretty brief. They last just during the ultrasound treatment itself, which, depending on the patient, would last anywhere from 10 to maybe 20 seconds total. All told, there might be 8 to 10 total ultrasound treatments. So I tell patients, when you add up everything, the amount of time you're lying on the ultrasound table, maybe an hour and a half, maybe 2 hours. You're not in the small MRI tube that whole time. You're sliding in and out pretty regularly for routine adjustments and testing of your tremor. So I tell patients the longest uninterrupted time you're going to be in the MRI tube is 20 minutes. So, that's not terribly long. The whole procedure, all 4 steps, takes maybe 2.5 hours. And so once you're finished, we disconnect the frame from the ultrasound helmet, take the frame off you go to recovery, they give you some snacks, and then you're discharged. And so what can you expect? This procedure works immediately. So the idea is that you come in with tremor, and then, 2.5 hours later, your tremor is significantly reduced. We know that reducing tremor can lead to improvements in quality of life. So people are able to perform activities of daily living. So things like feeding themselves, writing, keyboarding, what have you. There's also, improvements in mental health. We've seen a lot of people come to us and say, hey, my husband had this procedure and he's just like a different person. He's so much happier. He's not frustrated that he can't do all these things, As stated, it's an outpatient procedure, so no overnight hospitalization. Since we're not cutting you open, putting anything inside you, there's essentially no risk of infection or bleeding in the brain. We're not using any sort of radiation. This is MRI, so it's not a form of radiation. There's no anesthesia complications because we don't use any, general anesthesia or sedation like that. And on the whole, there are minimal complications. And we'll go into in a couple slides what those complications might be. So who is suitable for this therapy? You have to have a confirmed diagnosis of medication refractory. So again, that means you've either tried the medications and they didn't work, or you tried the medications and they gave you some bad side effects. So you have to have either essential tremor or a specific type of Parkinson's disease, which is called tremor dominant. You got to be older than 22 for ET or 30 for Parkinson's disease. As you saw in the video, patients are awake during the procedure. That's important to us because we have to talk to you, we have to assess you, we have to, assess and test your tremor. So you got to be able to tolerate lying flat and, at least having like a 20-minute MRI. A lot of people ask us, I have a medical implant like a pacemaker. Can I have this procedure? Possibly. I think some people might be, maybe misinformed that if they have a pacemaker, they can't have this procedure. A lot of the newer pacemakers are indeed MRI compatible, and we have treated a number of people here successfully with pacemakers without issue. It is true some of the older pacemakers might, eliminate you from this procedure, but, just having a device in doesn't in and of itself exclude you from this procedure. Having prior brain surgery doesn't also exclude you from this procedure. We've treated a number of people who have had a variety of surgeries on their head in the past without issue. There is this idea of the skull density ratio. And so this is not quite how thick your skull is, and it's not quite how dense your skull is. It's maybe a combination of the two. But, all jokes aside, people can't be too thick-headed or dense to have this procedure. The ultrasound beams have to pass through the skull in order to get to the brain. And so for patients who have a skull density ratio of, generally we would say less than 0.04, we would say maybe this procedure might not be for you. 0.04 doesn't really mean anything to you guys, but I will tell you, of the people that we see, 80 to 85% of people have skulls that qualify for this procedure. We can calculate your skull score based off a CT scan. To be clear, the CT scan does not have to be done here in Seattle. We see patients from all over Washington and out of state. These CTs to calculate your skull score can be obtained locally. And so here you have a brief video of a gentleman before and after focused ultrasound. You can see he was having difficulty drinking. Same thing with this lady here. And so what can you expect? 73.1% on the right, you see that's the amount of tremor benefit you can see at 5-year follow-up. That may or may not sound like a lot to you. I tend to think that's a lot. Studies show that amount of tremor reduction will translate into significant improvement in somebody's quality of life. It allows them to, again, perform activities of daily living. As we talked about earlier, we see a lot of improvements in mental health. People can return to the things they want to do, whether it be work, hobbies, or what have you. Recall that this procedure works by using ultrasound to make a small burn in the brain. And so what happens as soon as we finish making that burn in the brain, inside your brain, there's a little bit of swelling that generates around that little pea-sized burn. And that's a very normal body response. That swelling will start to develop pretty much right as we finish the procedure. And as that swelling develops, it can spread into areas near the tremor center that are responsible for sensation as well as movement. And as it does, we find that it can cause very characteristic side effects, which in most cases are temporary. So the most common side effects that we see after this procedure are the following. So if we treat somebody's right hand, we might expect patients to see right hand numbness, maybe on these fingers, maybe right tongue, lip, and mouth numbness. That might cause you to slur your speech. That might cause your taste buds to be thrown off a little bit. And then sometimes patients are a little bit wobbly on their feet. So very characteristically, if we treat somebody's right hand after the procedure, they might, when they walk, veer off to the right side. Now, what happens inside your brain is 1 to 2 weeks after the procedure, that swelling will start to get better and eventually go away. And as that happens, we do note that a lot of those side effects do get better. A lot of those side effects do actually go away. There is a small risk of a permanent side effect, which, I will be honest with you, if and when people have that, most people aren't particularly bothered. So they might come back to me and say, hey, doc, my hand's really steady. I do have a little bit of numbness on my lip. Doesn't really bother me. I'm glad to have had this procedure. Or they might say something similar about a little numbness on their hand, something like that. Where can you get this therapy? This is a Google map of all the focused ultrasound centers in the United States. Full disclosure, there's one in Honolulu, but I couldn't fit this on the map. You see a lot of these centers are clustered in, the East Coast, Midwest. You can see where I am up in the upper left here in Seattle. We are the only institution in Washington with this therapy. Swedish was the first institution in the Pacific Northwest and one of the first institutions in all of the country to have this therapy. They, along with the University of Virginia, were also involved in trials almost 10 years ago to demonstrate that this was an effective and safe therapy. And so where are the patients that we were treating coming from? This is a zoomed in picture of Washington and the greater Pacific Northwest. As you can see, a lot of our patients are clustered in the Puget Sound area. However, we see patients from, the Idaho Panhandle, Montana, all the way down to Southern Oregon. If we zoom out a little bit, we've had people come to us as far north as Fairbanks and as far south as Arizona. In terms of insurance coverage, this is Medicare covered in all 50 states. There is increasing recognition by insurance companies that this is a very effective and safe procedure. Full disclosure, many years ago, a lot of private insurance did not support this. However, we see this as less and less of an issue as time goes on. This is a video that I'm going to play. This details a patient that we treated here a number of years ago. So I'm just going to play this and I'm going to let you hear Bill tell his story. Oh no, did that not work? Sorry.
Well, my name is Bill Bazanson. I'm 76 years old. I'm here to talk about the surgery, the brain surgery that was done for me at Providence to stop the essential tremor that I had that was taking over my life.
What does it mean to be healthy?
Ooh, that's a good question. I think that just means being able to do the things you want to do in life without, pain, disability, or difficulty.
A year and a half before I had the surgery done, I started noticing little shakes in my hand. They started to interfere with cooking. All of a sudden I'd splash myself. I couldn't eat soup and I couldn't eat cereal. Well, it got worse. It got to the point where I couldn't even use my right hand.
Ultrasound has been used in neurosurgery for a long time, actually. And then in the early 2000s, there were some developments in kind of the physics side of ultrasound that enabled physicians to deliver ultrasound through the skull without removing any sort of portion of the skull. And so that made it very attractive.
Everything that you do with your right hand, if you're right-handed, everything was affected. It's embarrassing to get a glass of water from somebody and you spill it, and you automatically reach for your with your right hand because you're right-handed. Just imagine if your hand shakes and you can't control it, and that's what it was.
A lot of these folks, when they start, they can't even get the pen to the paper. They'll just kind of tremor kind of like this and not be able to draw a nice smooth spiral. We always start with a kind of a before, where we get kind of a baseline, and as we give more and more ultrasound, we continue to test them, and you'll see the slow kind of incremental improvement in their tremor, which signifies that we're in that correct spot. And then once we're there, we give more energy to kind of seal on the burn. So that whole procedure lasts about 2.5 to 3 hours.
I knew at that moment, the moment I drew the spiral correctly, that it was over with. It's an awfully good feeling.
We'll see patients in follow-up at 3 months and a year, and it's always great to check in with patients and see what they're able to do, and they are often excited to tell you what they're now able to do. I think that's important.
This was an example of my spirals before, and number 7, they're beginning to improve. And this is when they dropped me out after everything was done. The spirals are spirals. There's quite a difference. This was done this morning. So, no shakes. I'm so pleased, I can't tell you.
There was an example of a lady who had this procedure done, and she sent us in like kind of a stitch work of what she was able to now do. And so that's kind of the best day I could have, where you're able to perform a procedure which has an immense positive effect on someone's life.
Can you sign your name for me?
That's something I was never able to do. I just feel appreciation for being able to write again, to sign checks again. I feel human again.
So you guys can see, you know, Bill's story. You can see how profoundly that affected him. You know, Bill's a very memorable patient. He's done very well. We're pleased with him. But you know, Bill's story is fortunately not unique. We have a lot of patients like that. I followed up with a guy recently from the Olympic Peninsula. He had this procedure earlier this calendar year, and his own words were that he felt born again. You know, he liked to cook, but couldn't. And now he's able to cook. He says, "Hey doc, now you know, cooking's fun again. It's not like a chore. I can enjoy the things I want to enjoy." And so, you know, those things are what motivates us to be able to provide this therapy to patients in Washington and beyond. So these are just some recent cases that we've done, just some before and after spirals of patients. These aren't cherry picked. These are just some recent patients that we've done here in the summer. This is a lady, this is a nurse actually that we treated here in May, and the left is her before, the right is her after. Okay, and you know, if you seek treatment here, you know, some of the patients that have treatment here, they do, they get my work number because, you know, as you guys might be aware, sometimes calling the hospital line is not super efficient. So this lady had my work number, and then afterwards, she texted me. So you can see this is the time stamped, you know, 2:19 p.m. And so she just sent me a photo of herself, and all it says is eating soup, right? And so I think there's a couple things to note from that, right? So one, she's able to eat soup, she's able to feed herself, which is fabulous and great. And two, you know, it's like she had this procedure, and then, you know, an hour or two later, she's out at a local restaurant eating lunch, right? And so that highlights the fact that this doesn't require any sort of stay in the hospital or anything like that. And here we have a example of patients before and after spirals and handwriting. And actually, this is a patient that we treated earlier this year, and she's taken some time out of her day and has been gracious enough to be on this call with us to answer any sort of questions that patients might have from a patient's perspective. She's actually joined by her sister, who also had tremor and also underwent this procedure here at Seattle. And so with that, I will leave this up, and I will let, you know, Marty and Susan, you know, share their experience with ultrasound from the patient's perspective.
Hi, I'm Marty Presley. I am 70 years old and I live in Lebanon, Oregon. And this is hard. I get a little emotional because it has changed my life. I started experiencing the tremors when I was in my mid to late 20s. And it was starting to show when I would hand patients receipts, when I would try to use the calculator to work up patients' bills and things back before computers. It was embarrassing. It was debilitating. But it had not gotten as severe as it was when I hit around 50. It really started to get bad. I would have to wear patterned clothes because when I went to eat, it would go all over. And when I would, I eventually made myself some bibs to wear. And if that's not embarrassing, I don't know what is. But yeah, so many things had happened. A lot of these things that we see on a daily basis on what we can and cannot do, you know, they're so small to a lot of people. They think, oh, well, that's not a big deal that you can't, you know, you can't put your makeup on good, or you might burn yourself when you're using your curling iron. But when you add all of these things together that it just becomes such a struggle. And so when my sisters, they had their first hands done before me, which is something I regret that I didn't do right away. But they were so happy and so excited and so elated that I had no doubt that when I was ready to go have it done, after their first hand, the 9 months was over. And so then I had my first hand done when they had their second hand done. And I was one of the cases where my skull was a little denser than my sister's, as Dr. Wong well knows. So mine was a little more intense than theirs. But even though I might have experienced more pain than they did, I'm ready. I'm ready to have my second hand done. That would not dissuade me in the least. The benefits they just so outweigh any of the things that might be perceived as negative. And so I'm anxious to see Dr. Wong again in person with his wonderful staff. Oh my gosh, amazing staff. So I will be seeing him in February, I believe, February,
Yeah.
March.
I think
For
February,
my-
March, I think we've got
Yep,
a
for my second
date
hand.
earmarked.
This is my right hand. This is my left hand. So I'm ready whenever you are. Okay, Susie,
I don't know where I am.
where are you?
Well, let me
Oh, there
see.
you are.
I'm here.
Sue. Yeah,
Okay.
look down.
Oh, there I am. I am the oldest of the three of us that had the procedure done. The wisest, but I think around when I was about 25 years old, I was in nursing school. And I think my nursing instructor decided that I really hadn't noticed that I'd had tremors that bad, but she noticed that when I was giving injections and stuff, it just, I was afraid because I was wiggling, and I'm sure the patients didn't appreciate that either. And so my instructor said, Sue, meet me in my office. And I'm like, uh-oh, here goes my license. I'm not going to be able to be a nurse. And I went into her office and she put this little bottle of solution on the table and she said, draw that up and give me a shot. And, oh my gosh, there goes my whole schooling. And that kind of opened my eyes to the fact that I did have an issue. And back then, people really there really wasn't anything you could even do about them, I don't think. That was like in 76, 77, something like that. And so, of course, when I went into nursing, I did get my license and I went into nursing. And every time flu season came around, I would call off sick. I would hide in the closet just so I wouldn't have give anybody a shot, But I'm now a retired nurse, and I wish I was nursing now because I wouldn't have any problem with it. But some of the things that became really an issue for me were choir. I was in our choir at church and my music was flipping and wiggling and falling on the ground. And so I quit the choir. I stopped wearing makeup a long time ago because I kept poking myself in the eye with the brush. And I said, you know what? It's not worth it. So then, I don't know, just being out in public, people would mention that, are you okay? Your hands are shaking, and I'd say, yeah, I know I shake, but nobody ever, even when I went to the doctors, they didn't mention there was anything that they could do about it. So then one day I happened to be on the computer and I noticed a wasn't a webinar. It was more like an ad for the company that does this essential tremors thing with focused ultrasound, and boom, I got on, read everything I could read about it, shared it with Peggy, shared it with Marty, but she wasn't really interested in it. So Peggy and I started the process going, we had to find a neurologist. So luckily my doctor was open to sending me to a neurologist. So he referred me to a neurologist who knew nothing about this ultrasound procedure. And so he told me, he said, well, you could just, drink a glass of wine or something before you go on to your doctor's appointments, that'll help. And they actually gave me the wristwatch thing that you were talking about earlier.
Mm-hmm.
I have one. Medicare does not cover this.
Right.
Because it doesn't work. But so the company now is trying to get the money out of me for this little thing, but it didn't work. So anyway, as soon as I got my medications that I was supposed to take, I think we made an appointment with Dr. Wong in Seattle, and best day of my life. So I am totally excited. Both my hands are steady. I actually put makeup on without jabbing myself, and I can put it back in the container after you use it because my other hand is steady too. So
I can't. Not yet.
yeah. So I don't know. I just think it's the best thing that ever happened to me.
Thanks, Susan and Marty, again, for sharing your story and taking time out of your day. I do appreciate that. I think at this point, if there are questions from the audience, I would be happy to answer them, or if there's questions for Marty or Susan, we could field those too.
Yes, so we have quite a few questions coming in the Q&A. So to everyone in the group, just again, if you have any questions for Marty, Sue, or Dr. Wong, just please put them in the Q&A and we'll get to as many as we can. So Dr. Wong, the first few questions are going to be for you. And I know I know you kind of talked about some of these things, but if you wouldn't mind just kind of touching over on them again, just because some people may have joined late. So
yeah, absolutely.
The first question that we have here is, how does this treatment differ from deep brain stimulation? So maybe just a quick overview.
Yeah. So they both target the same area, right? And so, in essential tremor, there is in essence an area that's overactive, and we aim to reduce that activity to therefore reduce tremor. Deep brain stimulation, while very effective, is an actual surgery where we have to cut you open, put a wire into your brain and a battery pack into your chest. Focused ultrasound treats that same overactive area of the brain. However, provided your skull meets criteria, we don't have to cut you open, drill a hole in your skull. We can use ultrasound beams to make a small targeted burn in that same overactive area to therefore reduce tremors on the opposite side of your body. So, they're similar in the fact that they treat the same disease and they treat the same area of the brain, but they're fairly different in how they work. One is incisionless. The other does require an incision, could be perceived as more invasive. But to be clear, I'm not, obviously we're here to talk about focused ultrasound. Full disclosure, as I said earlier, we do DBS here as well. Here at Seattle, it's a procedure that is effective. But a lot of people I see, when you tell them, hey, we're gonna, drill a hole in your skull and put a wire in your brain, they tell me thanks, but no thanks, right? And that's not an uncommon reaction.
Perfect. Thank you for that. And the next question is going to be, would this treatment, focused ultrasound, be beneficial to someone who has already had DBS surgery?
Possibly. Now, if you have DBS in place, you cannot qualify for this. In order to have focused ultrasound after DBS, you have to have the DBS removed first. Full disclosure, we have treated a number of patients who exactly fit that bill. We've treated 2 women here in Washington, they're Washingtonians. They had DBS that was effective, but they got complications with infection. And so the DBS had to be taken out. One of these women actually had DBS twice. So she had it once, was effective, got infected, they had to take it out. She had it put back in, never got any sort of benefit, requested that it get taken out. And so she came to our clinic wondering if focused ultrasound would be helpful for her. And it was. She is like Susan. She has since had both of her hands treated. She's very pleased with it. Another, lady had the similar story, but she didn't have DBS done twice, only done once, and it was removed for, again, infection.
Got it. Thank you. And the next question we have here, does the acceptance for this procedure depend on the degree of advancement of the tremor?
Yeah, so that's a great question. I get asked that a lot. Patients will ask me, is like, hey doc, is my tremor, bad enough to have this procedure? I mean, that's certainly one decision point that I take into account, but I think it's individualized for every patient. When you see us here, we'll ask you, like, what is it that you want to do on the other end of this? Like, what are your personal goals? What do you hope to achieve? And, with that, we can kind of tailor a plan as to whether or not this might be right for you. So I always give an example of, let's say you were like a 90-year-old guy who just sat on the couch all day and really didn't do much. Well, you could have really bad tremor and it might not be debilitating to you. But let's, for example, say you are, I don't know, 55, 60, and you're a dentist, right? You could have a very small amount of tremor that could be extraordinarily debilitating to you, right? To the point where, yeah, it would be, reasonable to consider something like this, right? A real world example is a lady in the Seattle metro area. She makes greeting cards. That's her profession. So she brought one of these greeting cards into me. They're very intricate and lots of fancy artwork and decoration. And, so someone who does something like that for their living, they might not be able to tolerate as much tremor as someone who, doesn't do these things. So the answer to your question is that, there's no like kind of, hey, you have to clear this bar for tremor. It's kind of an individualized and, personalized decision that we can make when you consult with me.
Perfect. Thank you. And the next question we have here is, what if your tremors are equal on both sides of your body? What would you recommend to do?
Great question. Again, that goes into, I ask patients, well, what do you want to do out of this, right? And if you say, I want to be able to write again, well, then I think, the answer is very simple, right? Then we treat your dominant hand. Most people who are, say, right-handed are going to want their right hand treated first, just because, right-handers like myself, we're going to use our right hand more often than not. Similarly, left-handed people are more often than not wanting to get their left hand treated. Now, with that said, every now and then we do see someone who is, say, right-handed. They don't have a lot of tremor in their right hand and they want to have their left hand treated, which is reasonable. But again, that goes into kind of figuring out what your personal goals are. But, kind of a blanket statement, generally speaking, we would recommend, unless there are kind of extenuating circumstances, to treat your dominant hand. So whatever hand you are, that's the hand we would likely treat first.
Got it. Thank you. And then is it absolutely necessary to shave your head for this procedure?
Yeah, unfortunately it is. There's no way of getting around that. Funny story. We treated a gentleman here in Seattle recently, actually last Friday. He's very pleased with it. Funny enough, his wife also had tremor, and they were both interested in this procedure. And I offered it to both of them, but the wife was a little skittish about having her head shaved, which, you know, I can understand that makes sense. But this guy is now on the other side of this procedure and he's really pleased. And, you know, he's kind of written to me. He's like, I'm going to try to convince my wife to do it now, you know, but yes, the head unfortunately does have to be shaved. So.
Perfect, thank you. And then the next question is, do the pins of the helmet penetrate your skin?
Yes, so they do penetrate the skin. They go through the skin and rest on the outside of the skull. So nothing goes into the skull or through the skull or into the brain. We take the pins out, those little like four kind of, they look like divots once we take the pins out, but those heal up pretty well.
Perfect, thanks. And then the next question here is, can someone with a dental implant have this procedure done?
Yeah, so that's a great question. Without knowing the specifics of the dental implant, I can't say for sure, but a lot of people have had this procedure with, say, like, they got a shoulder replacement, I got some screws in my spine or whatnot. A lot of medical implants these days are indeed MRI compatible. You know, that's part of, you know, our general screening. You know, do you have any surgical implants? If you do, our team will, you know, do the investigative work to figure out if your medical device is MRI compatible or not.
Perfect, thank you. And then this next question is regarding a patient with inherited ET. And the question is, are either DBS or focused ultrasound an option for someone with a task-specific ET? Task-specific currently, but patient does have a yes, very mild head tremor. It says the patient is a left-handed musician, and this is the only source of income and very important to their lives. Although ADLs are not effective yet, they have tried drugs, but it's still very difficult for them to perform. Calitrio is apparently not an option due to Raynaud's.
Yeah, so I think, task-specific tremor can be treated by either deep brain stimulation or focused ultrasound. In the past, not here, we've seen musicians, carry a guitar into the, OR, and, during a procedure, they'll play the guitar or whatnot. And, that is something I think could possibly respond to either focused ultrasound or deep brain stimulation. If you are indeed a musician and that's how you make your living, you could make the argument that indeed is an activity of your daily living, as that's how you provide food for your family. So
Awesome, thank you. And next question is, does this procedure address PD associated leg tremors and movement restriction?
Yeah, so this is approved for PD, tremor dominant Parkinson's. Parkinson's disease, as some of the folks on this call might know, is not necessarily just tremor. There can be other movement disorders related to slowness of movement, stiffness, like kind of abnormal cramping or dyskinesia. This therapy would restrict the tremor and is specifically indicated for a variant of Parkinson's called tremor dominant Parkinson's. Regarding leg tremor, we generally counsel people that this is, best served for your hand tremor. However, I will say in our anecdotal experience, one gentleman that we treated earlier this year, we saw him in follow-up and he says, "Hey doc, my hand is doing really well. And, my leg is actually a little bit calmer." And I said, "Hey, tell me more about that." And he's like, "Yeah, I drive stick shift and, my leg is easy. Yeah, I can, better, disengage the clutch and whatnot. I don't have, issues, hitting the accelerator or anything like that." So, we can see at times if people have leg tremor that possibly responding, but I would tell you that generally this might be better suited, or I think there's more experience regarding hand tremor or arm tremor.
Perfect, thanks. And the next two are going to be sort of similar to that. There's two questions. One is saying, does it work for speech, tremor, or head shakes?
Great question. Great question. So There are different types of tremor. There's what we call appendicular tremor. So that's tremor in your appendages, so your limbs basically. And because say my right hand is only controlled by the left side of my head. And so we figure that, okay, if we just treat one side, that your right hand tremor should get better. So that's appendicular tremor. There's something else called midline, or we call axial tremor. So this is tremor in the middle of your body. And because it's in the middle of the body, you know, we think that there's inputs from both sides of the brain. So we feel that in order to best treat that type of tremor, you need to have both sides of your brain treated. Now, I will tell you, having just treated one side of the brain, some patients have told us, well, my hand's doing great, but my head tremor didn't really improve. Other people have said, well, my hand's doing great and my head tremor got better, but didn't go away. That's just with one side. So we long thought that if we treated both sides, that the middle of the body tremor should get better. However, treating both sides of the brain with focused ultrasound is a relatively new thing. It was FDA approved in late 2022 in December. Ultrasound itself had been approved in 2016, but specifically treating both sides of the brain is a relatively new thing. So I, for a long time, would tell patients, hey, we think this is going to help your middle of the body tremor, but because it's fairly new, we don't have a lot of, you know, actual medical evidence to back that up. That is until somewhat recently. I want to say about a month or two ago, you know, one of my old mentor at University of Virginia, he published some results of these staged bilateral ultrasound treatments, and they showed that of the patients that have both sides treated, about a third of patients who had like a head or a voice tremor saw a benefit. And for those who saw a benefit, it was benefit comparable to hand tremor. So it was a reduction of, you know, 70–75% in the kind of the head and voice tremor. In my own anecdotal experience, having treated, you know, a handful of bilateral tremor patients, those who have had middle of the body tremor have seen improvement.
Got it. Thank you. And then this next question is kind of a two-part question. So the first part of it is, do you have any opinion about the use of transcranial magnetic stimulation to treat tremor? And then the second part of it is it recommended to use focused ultrasound treatment before the tremor becomes really bad, or to wait till it becomes, you know, more prominent? And it says, you know, I understand tremors worsen over time. So we're just kind of wondering, you know, should they wait, or, you know, maybe get it more?
Yeah. So regarding the magnetic stimulation, that's not something I have a lot or any experience with. I am familiar with TMS is. You know, the thing with TMS is, you know, one, I don't know that it's effective for tremor, and two, even if it was, you would have to use the TMS continually. So I don't know how that would feasibly work. Regarding the second question about, you know, tremor's not that bad, should I have this procedure or wait? You know, if the tremor's not that bad and not affecting you, you know, I would recommend, and, you know, take this from someone who does this for a living, I would wait until it started to affect you or bother you in your life, right? If you have a little bit of tremor and it doesn't really functionally affect your day-to-day life, then, you know, I think while this procedure is, you know, I believe in it and it's great, you know, there are some risks in it, albeit quite low, but, you know, maybe wait until the tremor is more bothersome and disabling in your life before undertaking you know, a surgical procedure.
Great, thanks. And I'll answer the next question. So the question was, will this presentation be available to download later? And the answer is yes. We will be able to send out this presentation to everyone who attended or signed up for the presentation. So I just want to make sure that everyone is aware of that. And then here's a question for both Marty and Sue. How long has it been since you've had your procedure done?
Well, let's see. We had it done in June, on June 7th, actually. So we've had our 3-month post-op follow-up, and the hair does come back. don't worry, it does come back. Not, it seems to be a little grayer. What do you think, Sue? Turn your sound on. She's muted.
Oh, I think we're having a little trouble with.
There we go.
Oh,
There
there
you
she
go.
goes.
Yes, it does grow back. I've had it cut 3 times now. So,
We're kind of liking the short look.
Low
Yeah.
maintenance, I would
Love it.
imagine.
yeah, quick
Only takes
shower.
minutes to get ready.
Yeah. Just to follow up, Sue also had her second hand treated in June, but she had her first hand treated, I believe, in August of 23.
23, yeah,
Mhm.
yes. We also had a blast on the way home after we had our procedure, which was not really cleared, I don't think, by Dr. Wong, but
Yeah, I heard that these 3 sisters had a bit of a road trip down along the western United States. So
yes,
Yes, we
3
did.
bald girls, 3 bald golden girls trip
yeah.
blast.
And
One good thing though, because we left so early, our balance wasn't super duper, and so we didn't have to drink to have fun. So,
And we got a lot of sympathy. It was
oh yeah,
the 3 girls with do-rags on. So yeah, people treated us very nice.
they opened doors for us. They let us park, close.
Yeah, it was, yeah, we took full advantage.
Good.
And another question for you both as well. So, Marty, I know you had kind of mentioned, you talked a little bit about pain. So the question is, what kind of pain did you both feel, and how long did it last?
Well, for my pain, oh, bless Dr. Wong's heart. He brought me out and he gave me a look, and I said, "No, you're not gonna put me back in there again." He said, "Yeah, I'm gonna." And I gotta raise it, the intensity. I gotta raise it a little bit more. And I'm like, okay. The pain only lasted as long as I was in the machine, and I think it was like 10 seconds. It was very intense, very right across the top of my forehead here. But again, when you weigh it all out, that temporary short time span of pain was worth the results that I got. So it's not something I would ever say or dissuade anybody from having, because it was worth it. And again, I was more, my skull was denser, so he had to do more intensity. And that's okay.
Thank you, Marty. And how about you, Sue? Did you have any
Pain. The worst thing for me was just the helmet going on, and that was just temporary. I mean, once the Novocaine or Xylocaine
Lidocaine.
took effect, it went away. So yeah, was, well, if you've had a baby, you can take it.
My anecdotal experience is women tolerate this much better than men. Just throw it.
Yes.
Thank you guys for that. Dr. Wong, the next question would be, can a Graves' disease tremor be treated this way?
Well, if you have tremor related to Graves' disease, and for others on the call, Graves' disease is a thyroid issue, and so thyroid issues could cause tremor. We would probably recommend that the Graves' disease or the underlying thyroid condition be addressed first, because if it's a simple issue due to, a thyroid hormone imbalance, we should just treat the underlying cause before, doing something like this.
Got it. Thank you. And then another question for Marty and Sue. So this person said, my greatest fear is the loss of balance and slurred speech, especially the balance. If I fall due to loss of balance, then it's all for nothing. I don't know how to overcome this fear. How long and how severe was the temporary loss of balance for you both?
Well, for me, because it was my first hand, and Dr. Wong explained that my side effects won't be as much as after you have the second hand done. And so my being unstable didn't last nearly as long. I probably lasted 2 days, maybe. And as long as my husband was close by, or my sisters, well, they kind of veered off to one direction and I veered off to the other. So we kind of worked it out. So we kind of helped each other. But yeah, for Peg and Sue on their second hand, it was a little different, right, Sue?
Yes, it was. I think it was a couple of weeks before I got back to my normal. Normal for me was I do have balance issues, but the extreme was completely gone in like 2 weeks. And yeah.
The speech, that every once in a while that sneaks up on me. Yeah, every once in a while my tongue will feel a little thick when I try to say something, but I don't notice it as much as my husband does. And I'm perfectly fine with the way I talk.
Yeah, me too.
Nice. Another question for you both. Were you guys on any medications for your tremor prior to the procedure? And then since the procedure, were you able to reduce or eliminate those medications?
Well, for me, I have neuropathy. And so I'm on a drug. I've been on a drug, one of the drugs, gabapentin, that is one of the ones they suggest you try before you have this procedure done. And so I'll probably be on it forever. It never brought my tremors down. It never made them less the whole time I've been on it. The other 2 drugs that they had me try were
I think you tried primidone, right?
yes. And I call it psych drug, but I don't know what the technical term for it is. But those 2 drugs I couldn't tolerate. They gave me anxiety and I'm very tired. And on top of the gabapentin, which made me tired as well. So yeah, after I tried those 2 drugs in a matter of, I probably gave them each a couple weeks, I couldn't do it. And so my doctor was able to then give me the referral on to have the procedure done.
And none of us are on meds.
No.
For tremors now. So
Not for tremors, no. I have to continue to take the gabapentin only because of the neuropathy, but otherwise I wouldn't be on it.
Yeah.
Awesome, thank you. And then Dr. Wong, this one will be for you. So it kind of follows along with that. Is it a requirement to trial medications before this procedure is okayed by insurance?
Yeah, so insurance, in a word, yes, right? So because you have to be medication refractory, so you either have to try, and there's a variety of ways that you can arrive at this. You could try the medications and they either didn't work. You could try the medications and they gave you side effects, or some people have other medical issues, like let's say, real world example, we've seen a lot of patients who have low blood pressure and a low heart rate. And so if they have that, then, they might have a contraindication to try something like a beta blocker, which is well known to lower your blood pressure and lower your heart rate. So, but yes, you have to have some either refractory nature to medication, or you can have to have some sort of contraindication to try medication.
Great, thank you. And the next one is, given the contraindications for non-MRI compliant implants, what is the best way to find out if each of my implants I have are MRI compliant? I have cochlear implants in both ears. as well as dental appliances screwed in 4 implants in upper and lower, upper 4 and lower in 4. The permanent set of appliances are built using titanium bars. So what would
Yeah,
be the best
so
way
great question. So, we get a lot of, to date, I haven't treated anyone with a cochlear implant, but we get a lot of people with implants, whether it's like spinal cord stimulator, pacemaker, people got, dental implants. And how that works here at this institution is that our team will do the investigative work. We'll find out like what type of implant you have, make, model, go through your outside medical records. And then we forward that to our radiology department. And then they tell us, hey, Miss Smith or, Mr. Smith, these implants are indeed MRI compatible, or, occasionally, unfortunately, they tell us these are unfortunately not MRI compatible. So, we try to make it as easy as possible for patients. We don't ask you to do the investigative work. We can handle that.
And then the next question is, how does someone go about getting on the list for this procedure? What would the steps be to come see you?
We have an email, we have a phone. We do take self-referrals, so people can kind of refer themselves in. And how that would work is, you refer yourself to this clinic. You either can come into the physical clinic, see me face to face, or we could do a virtual encounter. And then, we kind of go over your history. I'd assess your tremor, do a medication review. And then, if your tremor is deemed to be refractory to medication, it's disabling, what I would then typically recommend is that we get a CT scan to figure out your skull density. And again, that CT scan does not have to be done here in Seattle. We've had people as, multiple states away get these scans. Sue got her scan down in Arizona. And once we figure out whether your skull's a candidate for the procedure, we would then get back in touch with you. And then if you have no further questions and want to have the procedure, then you can go about scheduling the procedure. I did want to also mention, as I said before, we do these procedures on Friday here at Seattle. As I said, it is an outpatient procedure, but one thing I did neglect to say, it is a 3-day affair. So we do the procedures on Fridays, but on the day before, on Thursday, we have you come in for a regular MRI. We use that MRI for GPS planning for the next day. So Thursday, outpatient MRI, Friday, outpatient treatment. And then on Saturday, you come back to the hospital for another MRI where we take a look at that small ultrasound burn. So for patients coming from, the Olympic Peninsula, Eastern Washington, or out of state, I tell patients, hey, plan on staying in Seattle on Thursday night and then Friday night. And then on Saturday, you can go back home. So, I think when Sue and her sister first did their firsthand, they flew back to Arizona either that Saturday or Sunday or something like that. And we've had, a number of patients come down from Alaska and, fly back up without issue.
Perfect, thank you. And then this one is for Marty and Susan. Would you be able to share any other side effects that you might have had after the treatment?
I actually didn't have any more than what I mentioned. I know Susie had a few.
Yeah, I had
interesting
a feeling like I had fuzz in my mouth, and I kept trying to get it out of there, and there was nothing there. That didn't last for very long, and I had quite a slur in my speech for a week or two. But like Doc said, the side effects for the second one are a little bit more intense than the first, and they went away. So I do. The fuzz is gone.
The fuzz.
Thank you. And Dr. Wong, so there's a question here. So someone is interested that's from out of the country.
Okay.
And so they wanted to know, they had a few questions. One is, what would the cost be if someone isn't using insurance essentially? And then if they were, coming to get the procedure, would they just come for that 3-day period, or would they have to make multiple trips here?
Is this person from Canada?
Um,
You know?
they said they're from Asia.
Okay.
Yeah.
So if you are an international patient, this has come up a couple times because we have gotten some inquiries from people from British Columbia. To my knowledge, international patients, we do not, unfortunately, the insurance is not good, so it would be an out-of-pocket expense. The out-of-pocket expense, if you were to just come with a briefcase full of cash to the hospital, is and don't quote me on this, I think it's somewhere in the neighborhood of 30 or maybe 40,000 US dollars. Okay. It does get a little tricky, though it's not impossible, because you would still need to be here for those 3 days, Thursday, Friday, and Saturday. We would have to find some way to do some sort of consultation, because I would like to, evaluate you and make sure your tremor is indeed, appropriate for treatment. That's why I asked for Canada, because for some of the Canadian folks, what they could do is just, pop down over the border and do a virtual visit, and then we can kind of get around that way. But if you're in Asia, unless you maybe have some family in Washington or something, and you don't want to come to Washington, we would have to have some way to by the book legally consult with you. Does that? I don't know if that. I think that's the best answer I can give for that.
Yeah, I think that's fair.
Yeah.
And then next question is, could someone just, is it just one treatment they have to come in for?
Yeah, so it's just one treatment on Friday. Susan had 2 treatments, but we treated her right hand in August of last year, and then her left hand in June of this year. But yeah, it's just one treatment here. It's about a 3-hour procedure. We do them on Fridays, so the first case starts unfortunately pretty early. Patients get here at like around 5 in the morning. We start around 7, and I think usually people are out of the hospital probably around like 10-ish. But yeah, just one treatment.
Okay, thanks. And then this next question says, I was born with essential tremor. I have used propranolol since 1985. Is it still treatable?
Yeah, I mean, if we've had patients who have been on these medications for years and decades, and so if you have tremor that's disabling and it is indeed consistent with essential tremor, I don't see why this couldn't help you. But if you're curious, we can always, if you live in Washington, you can come down to see us, or we can schedule a virtual and we can always chat more.
Great, thanks. And then this is a 2-part question. First part is for Marty and Sue. Did medications not work for either of you? And then for Dr. Wong afterwards, how poorly does a medication have to work or not work for someone to be eligible for focused ultrasound?
Well, I was put on medications for I think I took propranolol for a month, and then they put me on another one I was on that for about a month and a half, and nothing, it didn't, even drinking the wine didn't do that. Didn't do anything. So no, neither one of them worked for me.
Yeah, and I know our other sister who also had it done, nothing worked for her as well. And mine didn't work at all. Like I say, I was on mine for maybe a couple of weeks each. I think because it was more of a psych drug that they don't want you to feel anxious. And so yeah, I think it was more of it's okay, don't have to do this for months, before we can deem whether or not it works for you. So yeah, those 2 that I took were only for a couple of weeks.
Yeah, and what Marty said about that medication, the primidone is not an uncommon thing. So people say, yeah, I took it and I felt super anxious or felt depressed or sleepy or tired. We're not going to make you, take it months and months on end just to know it still doesn't
Right.
work, right? We do, I will tell you, on the converse, some people have come to us and they haven't really tried medication, and that's fine. And, I say, well, why don't we try these medications? I will tell you that there have been some people who have been put on those medications and they say, hey, you know what, didn't cause me those side effects. And, my tremor's not gone, but it's better. And so they say, well, maybe I'll keep this ultrasound in my back pocket, if and when the tremor worsens. But there isn't really like, I'm going to make you try this medication for that long or that medication for this long. I mean, if you want to get into it, there are probably, beyond propranolol and primidone, like, 4 other second line medications that you could try. You don't have to, but there's no like hard and fast, hey, you got to try it for this long for it to not work. I think if you try it and you either personally have side effects that you don't find tolerable and or you don't find that the tremor is actually getting better, I think that's kind of enough for me. Now, with that said, I don't think you can just take one pill and just say, hey, I've tried medications and quit. But like, this, it's I think a couple weeks is a very reasonable thing.
Thank you. And next question is, why do you have to wait about 9 months to do your second hand?
Great question. So historically, and when I say historically, I mean decades ago, there were older, shall we say, more archaic ways of burning the brain. And so this did not entail using ultrasound. This entailed making an incision, drilling a hole in the skull, and putting a probe into the brain, and then heating the tip of the probe up to burn that tremor area. And so that procedure, is effective. However, we in the medical community found that procedure, when you did it on both sides, did cause a lot of, shall we say, intolerable side effects of, balance, speech slurring, swallowing difficulties. So for a long time, the medical community said, maybe we don't burn both sides of the brain. However, focused ultrasound then came on, and, with 21st century technology, with, intraoperative MRI, to the point where we can measure within like the second, how big and how hot this spot is. There was thought that, okay, well, maybe with this kind of newer technology that's not so archaic, if you will, maybe we can, revisit the possibility of burning both sides of the brain. And so studies happened in the late 2010s, early 2020s that did show that we can, do both sides of the brain safely. And so the reason we wait 9 months is we want to make sure that, one, that you're happy with the procedure. 2, that any sort of side effects that you might have from the first procedure resolve, or at least, significantly improve before doing the second procedure. Susan alluded to, and I tell patients this, when we do the second hand, the side effects are a little bit, in my experience, a little bit more intense and might last a little bit longer. So we want to make sure that we kind of wait a while before any potential side effects that you have from your first hand wear off, because it is kind of like a, potentially cumulative additive effect. So that's why we wait the 9 months. I did have one patient who was a woman tell me that, oh, it's 9 months. Maybe it's like kind of like giving birth. Maybe you want to like wait 9 months before like the trauma, like of that before you revisit it, in kind of a tongue-in-cheek type way. But that's the reason we wait. So.
And then, do you know if this works for the VA? If someone has VA insurance, do you know if that would?
I don't see why not. We have been referred some people from the VA here, in the Puget Sound region, and I would assume if you're VA, it's Medicare. Medicare approves this in all 50 states, so I don't see why that would be an issue.
Perfect. And next question is, if you had this procedure done, so let's say you had it on your right hand, will you ever need to get it in the future? Or is it just a one time and
Yeah, that's a great question. So like the question of could your tremor come back? Possibly. We don't see that very often. I will say, you know, in the decade or so that I've been around this, we have done repeat. So like if someone, you know, had a good result and then for whatever reason a tremor came back to a certain extent, you know, that it can be repeated. So I will say that I can count on, you know, one or two, perhaps three fingers, the number of times that's been done. But, you know, having this done once does not preclude you from having it done again if need be.
got it? And then someone was asking, does your entire body go in the MRI tube or just your head?
A great question. Maybe a better question for Peggy and Sue. I don't, you know, you never see your head and kind of your torso go in, but I you know, your legs are kind of sticking out through the end of it, right?
Right.
Yep.
Yes.
It's
But
it's
we
snug.
slide you in and out pretty regularly. So you're
Yeah,
not-
it's snug, but that's my fault, not the machines.
And then Dr. Wong, another question is, do you know how long the treatment will last? I think what they're
Yes.
asking is, you know, how long.
Tremor benefit. Yeah, so that's a great question. You know, it's a relatively young procedure in terms of medical, you know, terms. It was approved by the FDA in 2016. So I think this August it turned 8. So, you know, beyond that, we can't really tell you, you know, how long it's gonna last. However, studies do show that at 5 years out, people still have on average significant tremor benefit. You know, I think the figure I showed was a, you know, 70% reduction in tremor, which studies show, you know, that amount of tremor reduction will translate into significant improvement in, you know, somebody's ability to kind of function in day-to-day life.
And the next question we have here, if someone has this treatment, let's say again on the right hand, would it cause them to have more tremor on a different part of their body? Like if one side is fixed?
Yeah, that's a great
Well,
question. I don't necessarily think so, but I think, you know, realistically speaking, a lot of patients say, hey, I had this procedure done, and they like kind of notice tremor on the opposite side of their body more because one side of their body is calmer, so to speak. So I don't think it actually makes so say if we treat your right hand, I don't think it actually makes your tremor worse on the left, but I do think that people are aware of it.
You really do notice that more, only because I think this one doesn't. And so you're more aware now of how bad this hand really was, just because this one doesn't.
One thing that I noticed was that Dr. Wong asked me one time if my body or my legs felt like they had tremors, and I told him no. But after I had the procedure done, it was like my whole body was calmer. It wasn't just my hands, it felt like my body was too. So I must have had tremors down there, around there.
And then we just have a few more questions that we'll get through. If someone is ambidextrous, do you have any recommendation on which, you know, they said they're left-handed, but also very right-hand dependent as well?
Well, yeah, I mean, I think that depends, you know, that's part of the, you know, the personalization when you come see us, right? We'll ask you is like, what is it that you want to do, right? And so like, if you tell me, I don't know, like right? I'll ask you, well, what hand do you write with, right? If you tell me you want to, you know, brush your teeth, I'll ask you, well, what hand do you brush your teeth with, right? And, you know, when we talk about like, what are your actual goals, then we can figure out like which hand to treat first.
Got it, thanks. And someone said they are going on Medicare the middle of next year. Do you think it's better for them to wait till next year, or should they already start, you know, the process with you before that?
Great question. We've had some patients with private insurance around like 64, 65. I'll give you an example. One guy, he had one of these rare private insurances that didn't approve it. And so he just waited till he aged into Medicare and then had the procedure successfully earlier this year without any insurance snag. So, I guess it kind of depends on what your insurance is right now, because Medicare, doesn't put up any sort of stink, if you will, regarding
Right.
this.
That's true.
Yeah.
And then this question is, do you know what percentage of PD patients you treat compared to ET patients? Like, do you know, is it?
Yeah, most of the people that we do treat, full disclosure, are ET. There are some, I would say a smaller portion of patients, maybe 5 to 10% that have Parkinson's as well as ET. I think it's, some people who have ET also go on to develop Parkinson's. So I think there's maybe about like 5 to 10% of patients that also have PD.
And then one of these questions is, my movement disorder neurologist at Virginia Mason in Seattle, would they need to send a referral to SNI to get seen, or can they just call themselves?
Well, if your doctor wants to send us, that's fine. We do not require that. You are more than welcome to call us and refer yourself if that's how you wish to pursue things.
Okay. And then someone said, I have white matter disease. My white matter is at the stage of an 80-year-old and I am 64. I read a study that essential tremor and white matter disease might be related. Does white matter disease impact the result of a focused ultrasound, focused essential tremor?
Yeah, I don't necessarily think so. A lot of people as they age, unfortunately, do get white matter disease, whether it be due to small little like subclinical strokes or what have you. We've treated a number of people with this procedure with white matter disease. Without looking at the actual, MRI, I can't say for sure, but white matter disease in and of itself wouldn't preclude you or exclude you from this procedure.
Perfect. And then next question is, I've had MRI and results are not clear because of my head is shaking. I could not tell it was shaking, but how do you go about getting good MRI results if you do have, if your head is shaking?
Yeah, so great question. So we do an MRI the day before, right? And so part of that is I assess whether you have a head tremor, because we want that MRI the day before to be really crisp, because we use that for GPS planning. And so if you have a really bad head tremor, some of the patients that have gone on to have this, we will do that MRI with a little bit of sedation or anesthesia to make sure your head is still. We don't use anesthesia or like sedation during the actual procedure, because as we talked about, you got to be awake to communicate and test your tremor. The way we get around keeping your head still is the frame will just hold your head still. So we've had a number of people with head tremor, we put the frame on, and it's not an issue.
Perfect. And then if you're currently taking meds for ET, do you have to discontinue them prior, like for a certain period of time before the procedure?
We tell patients who are on PD meds, or not PD meds, essential tremor meds, to hold them the morning of, because we want to kind of see your tremor, quote unquote, at its worst, so we can most effectively treat it the day of the procedure.
Perfect, thanks. And then here's just the last two questions. So you had talked about, you have to do a few different things to qualify this for this procedure. They had mentioned see a neurologist, get a CT scan, do medication trial. Are there any other steps that are required to have this procedure with you?
Yeah, no, and you do want to clarify something. A lot of people with tremor are being managed by their primary care, right? A lot of people that we see are, in Eastern Washington or on the peninsula, where they might not have access to tremor. But, a lot of PCPs are familiar with this and, can and have managed people with tremor on these medications. If you come from a neurologist, great. But I don't necessarily, at this stage, need people necessarily to see a neurologist. I think, the easiest way to answer these questions are just, if you're interested in focused ultrasound, we have a pretty permissive policy, we're willing to chat and speak with you. I don't know, does that answer the question? I think, once you see me, we can kind of determine what steps you need to take. If you need to take any steps further at all, I think everybody's a little different, right?
Perfect. And that kind of leads into this last question is, let's say someone does want to come have the procedure with you. What is the wait list? So if they wanted to schedule with you,
Yeah.
how
So
long would it take for them?
if you came to me today and, we chatted and your skull checked out and all that. As of today, I think my scheduler told me, it's late September right now. Sorry, we're booking into maybe November, December kind of time frame at this point.
Perfect. Well, thank you so much, Sue, Marty, and Dr. Wong. We really appreciate you guys spending the time and sharing this, your experience with everyone today. Just wanted to thank everyone. If anyone has any further questions, please feel free to email us at swedish@swedish.org or call us at 206-320-4145. And again, thank you so much for joining the webinar, and we should be sending you a video recording in the upcoming weeks. So thank you again.